Okay, welcome everybody to our momentum discussion titled A Better New Normal for COVID-19 Vaccine Distribution and Administration. I'm really excited about our panel. It's a set of terrific scholars who have been working in this area with a great deal of experience. Let me just give a minute of background about the momentum discussions. These are topics selected by GSA because they're gathering momentum in the field of gerontology. They tackle hot button issues, things that we see brewing, things that may change the course of gerontology. And of course, the pandemic figures heavily in this kind of thing. And I'm sure there are many sessions where you'll learn about the pandemic. We're very pleased about our effort here because it's the culmination of 4 prior webinars we've had on COVID, our COVID conversations, where we've had 10 different experts in gerontology working in this area talk about their research with international perspectives, looking both at the mechanisms of disease, but also at the broad social impact of the pandemic. So we know that vaccines against SARS-CoV-2 are safe and highly effective. They've lowered the COVID burden. That's clear. Yet we face continuing challenges. Getting vaccine to vulnerable populations continues to be a challenge. And the focus of our momentum discussion today is what can we learn from our experience in these areas? How did we get vaccine to older adults who can't leave their homes? How well did we do in getting vaccine to long-term care populations, and in particular, care staff in these settings? This momentum discussion will review progress in achieving what we call a better new normal for vaccination of hard-to-reach populations. Let me just mention some of our panelists. I myself am Steve Albert. I'm a faculty member in the Department of Behavioral and Community Health Sciences at the University of Pittsburgh. I bring a public health perspective to vaccination and old age health. We also have Dr. Gordon Douglas, a physician with long experience in vaccine development. He's Professor Emeritus of Medicine at the Weill Cornell Medical College. He served for many years at the National Institute of Allergy and Infectious Diseases at NIH and was head of the Infectious Disease Unit at the University of Rochester, chairman of the Department of Medicine and physician-in-chief at New York Hospital Cornell, and spent many years with Merck Pharmaceuticals. We also have Dr. Jasmine Travers. She is an assistant professor of nursing at New York University at the Rory Myers College of Nursing. She's had a couple of postdoctoral fellowships, one at Yale and one at the University of Pennsylvania School of Nursing. She's currently a Robert Wood Johnson Foundation Career Development Awardee and also a Paul B. Beeson Emerging Leader Awardee through NIH. And finally, but not last, we have Terry Harvath, whose name should be familiar to all GSA members. She is the president and board chair of the Gerontological Society of America. She is also professor and senior director for strategic initiatives at the Betty Irene Moore School of Nursing at the University of California, Davis. Long history of research in family caregiving, and was director of the Hartford Center for Geriatric Nursing Excellence and Advanced Practice Gerontological Nursing at the Oregon Health and Science University. So we have lots of talent, lots of experience. I'm really excited to see what we can learn today. And I hope we have time for audience to weigh in at the end of our session. So let me begin right away. I also want to thank, before we launch in, the GSA National Adult Vaccine Program, NAVP, which Dr. Douglas is involved with, and also the staff at the GSA for terrific help in organizing the momentum discussion. So let's go right into it. And our first topic is, how did COVID-19 vaccines get developed? What was the process? Did it work as well as it could? Should the results be trusted? And I think we already know that a lot about clinical trials, that they are large efforts to make sure vaccines are safe and effective, involving tens of thousands of volunteers of different ages and races, ethnicities. And the results have shown that the vaccines are effective against severe illness and hospitalization and death, with new results showing that reinfection is lower in people who've been vaccinated, great benefit for the booster or third shot, and still great effectiveness against the new Delta variant. Every week, another CDC report comes out showing the benefit of vaccination, but also cautions that distancing, masking, and travel restrictions and testing remain important adjuncts to vaccination. And we can claim that adults in the United States, about 60 to 70% of the population have had the complete vaccine series, which is as high as 85% among older people. And yet, we still have concerns in the country, some doubt that vaccination is the right thing. And even among care staff and even among healthcare professionals, and certainly among populations that are highly vulnerable. So I'd like to begin now with a long-term perspective from Dr. Douglas, who's seen it all when it comes to vaccination. The question I posed to him earlier, I'll pose again. Where are we in the course of the pandemic? Have we turned a corner? Are vaccines doing what they should be doing? Dr. Douglas.
Steve, thank you very much. I think, I'm optimistic now. I think we have turned the corner. I think that the rate of Delta infection is dropping everywhere in the country. And I'm hopeful that it will stay down and that a new variant won't appear. But the future is unpredictable with regard to the epidemiology of virus infections, but it looks like that's the trajectory that we're on. I'd like to back up and make a couple points about the development of vaccines, because I think there's been some statements that have maybe been unfortunate out there. I mean, these vaccines, as you mentioned, are just remarkably, extraordinarily effective. They're remarkably safe. And the timetable for completion of the clinical studies was incredibly fast, 11 months, as we all know. And people say, well, that's compared to usual time for vaccine development, which is 10 to 15 years. And therefore, a lot of shortcuts must have been taken. And we don't really know whether they're safe or effective. Well, it's really a mistake to say that shortcuts have been taken. Let me just back up a little bit and say, the COVID vaccines took just as long, and I'll submit a case that they took 22 years to develop. The principal inventors of this vaccine were a woman by the name of Caitlin Carrico and Drew Weissman, who were at the University of Pennsylvania at the time, and they began working. She had been working on messenger RNA for years. She saw it as a way of getting a human cell to make any protein. So not thinking just about vaccines, but about many other diseases as well. They began in earnest, though. They saw the opportunity to make a vaccine with messenger RNA. And the problem with it was the molecule is very unstable. It's just impossible to hold it in a form. It's just there are many compounds that break it up and destroy it. But they learned how to stabilize it by inserting a couple of mutations and then wrapping it in a little lipid nanoparticle. So it's a little fat globule, actually. And in 2005, they published a seminal paper, which is the basis for the vaccine program. So from 2005 on, there's really vaccine development, but it's what we call preclinical research, but it's very much a part of the background of this vaccine. That's really an important point. It means that when the SARS-CoV-2 virus was first detected in China, and when the Chinese shared the genome of the virus with us, they were able within a few days to take that genome and make a prototype messenger RNA vaccine. That happened both at Moderna and at BioNTech, which joined with Pfizer at the time, as you know. So that's really important, because if they weren't ready to go, we would not have the messenger RNA vaccines. So, in one sense, we're lucky to have this wonderful basic research program there so that things are ready to go. Other things were done at that point. I mean, one thing I do have to say, the clinical trials were done in record speed, no question about it. And how did they do that? Well, whenever possible, they did things simultaneously, ran clinical trials at the same time rather than sequentially, what is usually done. I mean, Pfizer, people don't know this so much, but Pfizer went into phase 1 with 4 different vaccines. And they just looked at them competitively. Which one of those 4 produces the greatest antibody response, and which one of those 4 produces the least side effects? And that's the one they picked, and that's the one they ran with. The others they discarded. That kind of thing is not ordinarily done because it's too expensive to do it that way. No one's going to take a risk because you don't even know whether the vaccine will work in humans at that point. And I think everybody knows about phase 1, phase 2, phase 3 clinical trials, but they don't realize that the same kind of thing has to go on with what we call process development. How do you make it? How do you make it at scale? And you have to have those ready for the phase 1, phase 2, phase 3 trials. So if you put the manufacturing development and the preclinical science in together, these were very long development programs that produced this super vaccine. And so the other way that the manufacturing was speeded up is we threw a lot of money at it. We built manufacturing facilities at risk that maybe the trial wouldn't be successful and we'll never use it, that kind of thing. But we were able to do that because Warp Speed threw $12 billion at the program, picked some vaccines that might work, and many of the, half the vaccines they picked didn't work. They failed. People don't talk about ones, but Merck had a vaccine program, 2 vaccine programs that failed. Sanofi, another big vaccine company, had a vaccine that failed, and so on and so forth. So I think those are really important points that make you look at the safety and efficacy of this vaccine. And then a wonderful thing happened, the big trials that proved efficacy are called randomized controlled trials, a randomized double-blind, placebo-controlled and everything. And they're done in multiple sites and sometimes in multiple countries, but they're very heavily controlled. I mean, the people who are administering the vaccine are very experienced people. They're all medical personnel, they're very experienced. Once you get the vaccine out in the, that anybody is, CVS and the big convention centers and all kinds of places are administering vaccine, it's a different ball game. So after they're licensed, we do what's called effectiveness trials. And they're done, they're a little bit maybe more subject to bias, but if they're big and they're really carefully done, you can overcome that problem. And we initially, the effectiveness studies absolutely mirrored what we found out in the randomized controlled trials, which is really an enormous support. And we had 94% efficacy in a randomized controlled trial, and 3 months later, the first Israel effectiveness trial showed we had 94% effectiveness just in randomly using the vaccine all over the country with different observers, different administrators, et cetera. I made some comments here about the messenger RNA vaccine. The same thing could be said for the J&J vaccine, which is an adenovirus vector, common cold virus. And just insert the genome into the adenovirus and use that as a vaccine. That technology has been worked on by J&J for 20 years. So there's a big background here.
Let me jump in. I mean, many of the people who are a little less trusting of the vaccine should listen to you. And of course, one of their arguments is the supposed quick, rushed job. And yet despite the demonstration of effectiveness and the care and the extent of these trials, we still see some concern and reluctance. Let me turn to Dr. Travers. You have a perspective on sometimes a phrase people use, vaccine hesitancy, which may not be the best way to speak about this. Can you speak to this question?
Sure. Thank you, Dr. Albert. So we should not be using the term vaccine hesitancy, and that term has been around for a long time, but more and more so, it's polarizing and can be emotionally charging. So we need to think about using words more so like vaccine uptake and acceptance or willingness. The thing with vaccine hesitancy is that many are quick to blame vaccine hesitancy as a reason for gaps in vaccination, putting the onus on Black Americans, people of color, to develop better attitudes around vaccination. But the issue is that this hyper focus on hesitancy implicitly blames Black communities and communities of color for the under-vaccination, and it obscures opportunities to address lack of vaccination acceptance to the COVID-19 vaccination. So really understanding why those who are not willing or ready to accept the vaccine, what are those reasons rooted in, and how do we work towards addressing those reasons and supporting people in wherever they are. So meeting individuals where they are. For me, I live in New York, and former Governor Cuomo, every time I'd watch his press conferences over a number of weeks, he would say, we need to get these vaccine hesitant folks, vaccinated. And it got to a point where it felt like it was pointing the fingers at people. And that's how specific communities feel without actually being heard and feeling that people are listening to what their issues are. And it's not to say that, specific groups are still the main groups that are not being vaccinated, but kind of really taking more of an individualistic approach. So thank you for that, Dr. Albert.
Thank you for educating us about this issue, which I think is central. I wonder, Dr. Harvath, do you want to weigh in on this? Is there a perspective from the caregiver side? Do they face issues like this, and anything you can add?
Yes, thank you, Dr. Albert. I think in order to understand the caregivers, family caregivers' perspective on vaccination, we need to understand how they experience the pandemic. And I think they are a population that bore a disproportionate burden through the pandemic and continue to, because so many of the community-based services that support families in caring for older adults at home closed their doors or significantly curtailed their services. And so families were left to provide care often on their own. They were very frightened that they would be the vector of disease for their family member. And so I think felt very hampered and confined at home. Many of them were also cut off from seeing older adults who were in congregate care environments. I'm sure we all have seen those heart-wrenching videos of somebody waving at an older person through a window. And if the older person had dementia, they didn't understand why their children couldn't come in and visit them. And so I think that we've actually seen an increased willingness and acceptance for the vaccine among family caregivers because they saw it as something that they could do to protect the person they were caring for and to get some freedom from the confinement that they've been experiencing. A lot of hospitals throughout the pandemic closed their doors to visitors. They made exceptions for parents of minor children and partners of pregnant women, but no such exceptions by and large were made for family caregivers to frail older adults or older adults with dementia. And so many caregivers were faced with decisions of whether or not to bring somebody to the emergency department if they were ill, knowing that they would have to part with them at the doors of the emergency room and wonder what was going to happen and whether they would see that person again, depending on how ill they were. And so I think there was an urgency and a desire both for the freedom and for the protection among family caregivers. Some of the challenges, of course, were around how do you get vaccines into the arms of homebound older adults? And there have been lots of challenges with that, some of them logistical because of those vaccines, the Pfizer and the Moderna, that have refrigeration requirements. And in the early phases of vaccine rollout, we wanted to make sure that we weren't wasting thawed vaccine, and it's not very efficient to deliver vaccines to individual homes. And so I think there was that obstacle to try and get it out. There were also questions about reimbursement. Would home care be reimbursed if the only reason for making the visit was for a vaccine? And I think until some of that got clarified, there was some reluctance among home care agencies to take that on whole hog because of the expense and the staffing time that was involved. And so, I think families have been had a willingness to do that, to get vaccines themselves and for their older family member because of the freedom and the protection that they saw that it afforded. That, the older adults are also the generation that lived through, polio vaccines. And I think that recognition and understanding of the role that vaccines play in public health is probably more known to the older adult population.
Okay, thank you. So we have two topics to get to, and each of them is a long discussion in itself, but let's see if we can shed a little light. One is I've titled Getting Skilled Nursing Facilities to Own Vaccine Coverage for Their Workforce. And this has been a controversial issue, and maybe that's not the best way to phrase it. I took that phrase from a long-term care director who I know who said this was a priority, but I'd love to hear what the panel thinks about this. It's a problem. We have lower vaccine coverage or uptake among health workers in this setting. And what could we be doing about this that we haven't been doing so far? And what are the sources of this challenge? So first, maybe a little bit of a perspective from Dr. Douglas. I don't think long-term care populations are normally, we don't normally think about them for vaccination, a new vaccine, or am I wrong about this?
Well, we certainly have for influenza in the past. And, that there are many vaccines that are not pertinent to this population. But certainly with influenza, there have been a lot of efforts over years to improve vaccination rates in skilled nursing facilities, et cetera. And I think it's very important.
Dr. Travers, you've have some experience here. Is the influenza vaccine model for nursing homes, I mean, is it appropriate for, let's say, extending it to care staff in these settings? What has been the experience of the skilled care workforce?
Well, when just thinking about influenza vaccinations and what we can learn from that and how that can inform COVID vaccination efforts. For one, we see differences in influenza vaccinations among healthcare workers in acute settings compared to nursing home settings. So there are more healthcare workers getting vaccinated for influenza when compared to the nursing home setting. We see more mandates in when it comes to influenza vaccination in acute care settings in the hospital when compared to nursing homes. So of course, mandates are going to increase the actual vaccination uptake. One other important difference that we see when it comes to influenza vaccination is we saw differences among disciplines as well. So for example, physicians and our registered nurses are more likely to get vaccinated for influenza in both settings when compared to certified nursing assistants, for example. So when seeing these differences just from influenza, we should already kind of anticipate that we're probably going to see similar differences when it comes to the COVID vaccination. And then just thinking about some strategies and approaches to vaccination in long-term care settings that we can look at from influenza vaccination. Again, mandates, of course, helped with influenza vaccination efforts, but other strategies included declination statements. So where staff have to actually sign a form that says why they are refusing the vaccination. This really helped when thinking about the COVID vaccine for those who at the beginning said that they weren't going to get the COVID vaccine. When this was done one-on-one, so with maybe an administrator or an educator, a person was able to sit down and kind of really get more information about what did this declination kind of consist of? Was it, fears? Was it lack of education, misinformation? So that those conversations could be had one-on-one, and it could be, really supported in regards to what was it that the staff member was lacking. So that's kind of just specific to vaccination and looking at influenza vaccination and how we might see that informing COVID vaccination efforts. But I can also speak about the workforce as well.
Many hospital systems have now mandated vaccination. Do you see that happening in the long-term care settings, in the skilled nursing facilities?
Yes, we've already seen that in the nursing home setting. So now you're seeing upwards 97%, 98% of healthcare nursing home workers being vaccinated, with a small percent having being able to use the religious declination.
Okay.
Dr. Travers, can you talk a little bit about how staffing patterns and some of the shortages that are experienced in long-term care, is that influencing rates of vaccination among the staff at all? It makes me wonder whether there's a reluctance to enforce somebody to get a vaccine if you're worried that they may resign from their position and then leave you even more shorthanded.
Right. Well, of course, there's a lot of concerns with some nursing homes, and where nursing homes have even actually used that as a promotion technique, where they've said we're not requiring the vaccine, so that those who did decide to leave another facility because requirements that were coming, or because requirements that were implemented, they see other facilities and say, oh, well, this facility says they don't require vaccination, and they're outwardly promoting that. So we do see that that jump. And then also thinking about workers who say, well, I can go and work in a whole entire, industry, as opposed to nursing homes where they're not requiring the vaccination. So those were concerns, of course, from administrators within nursing homes in regards to, am I going to lose staff? And do I actually have the support to implement this type of mandate, where other nursing homes kind of stuck behind, their mandates and said, this is important. I'm really thinking about the care that's providing to our residents. And one thing just to kind of think about with nursing homes is that they were really, the core of the epicenter of the pandemic, with 40% of staff and residents dying from COVID. So really focusing on those who are working there, those who provide the primary care to residents, so the certified nursing assistants, and what will it take to really support vaccinations among those groups?
Yeah. Thank you.
Thank you. Excellent thoughts. Let's turn to the other question we have in our discussion today, and that is getting vaccine to community populations that receive in-home and community-based services. I think our audience knows that between 2 and about 4.5 million older adults are homebound. That is, they leave their homes less than once a week, and they do so only with great difficulty in some cases. Getting vaccines to this population was not easy. And we're talking about some large numbers, something like nearly 500,000 older people never leave their homes. So I think some research has come out recently that the pandemic may have made this situation worse. That is, people who would normally leave their homes did not because of social distancing requirements. So it was really quite a challenge. There's some sense, some evidence that the proportion of people homebound increased over the last few years. There are also some disparities in this population. White, non-Hispanic individuals are more likely to live alone, which may leave them without caregiving assistance. And Black, non-Hispanic, and Hispanic Latino individuals are more likely to live in multi-person households, which may increase their risk of exposure to SARS-CoV-2. So I think we've had lots of challenges here. Our healthcare mainly involves large capacity sites like hospital systems and health departments and large clinics and retail pharmacies. These are not very accessible to people who can't leave their homes easily. And so this group was in danger of being lost to our care system. Now, as Dr. Harvath mentioned already, getting vaccine to these folks is not so easy because of multi-dose vials, short shelf lives, concerns about wastage. These all create what are called last-minute challenges for vaccine for this population. So I'd like to raise some of these issues now. I do know, at least in our area around Pittsburgh, lots of creative solutions were developed. The National Guard got involved in some cases. 211 call hotlines got involved, EMS services. And I know in our case, our health department shared, our Department of Human Services shared information about older people receiving in-home and community-based services with the health department to alert the health department of the need to get vaccines out to these folks. But how well did we do, I don't think is so clear. And I'd love the perspective of folks in this group to think about this for a little bit. How well do you think we did? And let me throw that out first to Dr. Travers, and maybe others can weigh in as well.
Sure. So when thinking about older adults in general, right, older adults made up 14% of COVID infections, but 80% of deaths. And there was no question that older adults needed to be prioritized, meaning that they needed to be at the front of the line when it came to receiving COVID vaccinations. But how they were going to get to the front of the line was not clearly thought out, I would say. And it's just an indicator of how we look at access for one, for the COVID vaccine in this picture, but to access to healthcare in general, and how we need to really look at the various determinants, social determinants of health that may influence whether or not one is able to actually access the care. It's not enough just to say, okay, we are granting you access. You are going to be the ones first to get the vaccine, but then we really need to intentionally and thoughtfully think about what that looks like. So for us, we conducted a survey of 600 older adults across the country to understand difficulties that these older adults experienced when accessing the vaccine and what facilitated their access. And at least 1 out of 5 participants said making appointments, long lines, understanding instructions for signing up for COVID vaccines, transportation and mobility were barriers to getting vaccinated. And we most definitely would see this as ringing true to accessing routine care, for example, at your primary care provider, or accessing preventative measures such as an influenza vaccination or picking up medications at a pharmacy. If you don't have a pharmacy that is close by you, if you don't have the function to be able to get out and go access these services, then you're not going to be able to access them. So how do we see just attention to what access really entails for groups such as older adults, internet access, access to transportation and such?
So access is really the key, and it's a more general problem. And COVID vaccination access was only one element in this more general challenge, I think, is what you're saying, right? Dr. Harvath, do you want to weigh in on this at all? Yeah.
Yes, one of the things that we realized right away at UC Davis is that when a family caregiver was going to bring an older person in for a vaccine, they actually wanted to be vaccinated too. And because of the way that our health system in this country works, that wasn't always possible because they weren't necessarily UC Davis patients themselves. And we had to grapple with, how do we make sure that we are doing the right thing? And, we quickly made the decision as a health system that, yes, we would vaccinate the caregiver as well, even if they weren't a patient with UC Davis Health. But I can only imagine that was also a factor across the country, simply because we don't really have a well-coordinated healthcare system. And it's difficult then, how do we track this person we don't have a record for, how do we track them so that they can come back and get the second vaccine when they're bringing their older family member back? And so our health system isn't set up in a coordinated way, and it's certainly not set up in a way that recognizes that older adults have family caregivers who are often integral to their healthcare and their access to healthcare. On the personal side, my mother turned 90 yesterday, and one of my sisters, who's really her caregiver, spent 4.5 hours on hold getting her appointment for her first vaccine. And it was, the sheer determination of my sister that, got my mom the vaccine when she got it. And that's not possible for everybody to stay on hold for 4.5 hours waiting to get an appointment and wondering, is anyone ever going to pick up the phone? So we have many barriers for older adults and for their caregivers.
I think we all have stories like that. I remember getting a call from a family after I talked about this on the radio somewhere, that his mother was severely physically incapacitated, moderately demented. They felt they had to fire the 2 home workers that came in to help. They were overwhelmed because they were old and not in such good health themselves. Could I help them get a vaccine? They didn't have the wherewithal or experience to stay on hold for 4 hours and arrange vaccination. And there really wasn't that much we could do. And why should it be so difficult to get vaccine out to these households?
Steve, there's one thing that could be done technically. In an ideal world, originally the vaccine would have been put in individual syringes.
Right.
I mean, that's where you'd like to.
Right.
That's an ideal way to administer vaccines. Pre-filled syringes, you don't have to worry about the dose or anything. Impossible to do in the face of an epidemic, and therefore multiple dose vials were used. But you could make a small number of pre-filled syringes that could facilitate a go to the home and vaccinate individual patients.
Right.
You wouldn't have the problem of wasting vaccine, et cetera.
Right.
And a small point, but I think it could encourage home visits for that subset of population that absolutely cannot go to some place to get vaccinated.
Well, I think a lot of these sorts of practical flexibilities that we don't have in our delivery of medical service or healthcare services. And maybe we need to be a little more flexible in this area. Well,
one of the things I also just want to point out, because we've been talking mostly about this in the United States, and I think it's important for us to recognize that GSA is an international organization, and that there are many countries that have even less access to vaccines, and even countries that we would think have a healthcare system that should be able to respond, has been subjected to, challenges. I have a good friend and colleague who's a primary care physician in New Brunswick in Canada, and they have one refrigerator in the entire province that could keep the vaccines chilled to where they needed. And so they, needed to place it centrally within the province so that there could be access to this. And so when we think about other countries and rural areas, and the challenges that have to be overcome in order to get wider spread vaccination, it can seem daunting.
Right. And I just wanted to add to that, and something that Dr. Douglas brought up. So there were providers who were going into the homes and actually um, administering the vaccination for homebound older adults. But there's some also questions just with access for that. So what about older adults who may not be connected to a healthcare system or provider? How do we identify those older adults who are not connected to a system already, who do not have family members who can actually, set up appointments or try to bring them places or notify someone of the need for a person to come into the home? So it's a number of layers of access issues that we need to address when it comes to vaccination efforts.
Thank you,
Other
Dr.
efforts.
Travers. Definitely a good caution for us and shows how far we have to go. Well, our time is up, and we do want to leave some room for our audience. I'm sure we've raised lots of issues. We have identified and I think shown some insight on a couple of key issues: the challenges of long-term care delivery of vaccination and the challenges of reaching our most vulnerable community dwelling older adults. Big challenges. And I think Dr. Travers is reminded, we don't want to blame anybody. We don't want to blame victims, certainly. What do we need to do to make our system more flexible and nimble so that people are not lost to a life-saving technology? And so let's end on that note. I just want to thank again our panelists, thank GSA for pulling this together, thank the GSA National Adult Vaccination Program for its continuing work in this area, and thank our audience. And I hope we've spurred you to think about some of these issues. And please feel free to tap us now with questions. And please, your own personal experiences on how difficult it might have been to get vaccination to these populations, or what kind of creative system level hacks you might have come up with to address these issues. So thank you again. And we'll end here and turn it over to you now. Thank you. Well, thank you, everyone, and all our participants. This is the first time we, the panelists, have seen the recording, but it's fresh in our minds because we did it not so long ago. We have Dr. Travers with us only for a little while because she has to jump to another session. But I would love some questions from the audience, but if none for now, let me throw one thing out. Even in the week since we recorded this session, we've had a couple of big changes. One of them is the new extension of mandates. Another is the new access to vaccination for the pediatric populations. It is such a fast-moving picture that it's very, very hard to keep up with. Let me just throw a question out to Dr. Travers. What do you think will be the impact of mandates? They are taking root more in healthcare settings. Do you think this will make it easier for care staff to be vaccinated and maybe take some of the burden off of them in making such a decision?
Right. I think it will take some of the burden off of the nursing homes when it comes to the mandates and the concerns about staff leaving, because before, like I said in the presentation, you had other nursing homes kind of promoting that they did not have the mandates, and other industries that you could kind of go to when thinking about, I don't want to get the mandate, where can I work that's not going to require that mandate? But now, as we're seeing more and more facilities and organizations that are requiring the mandate, it's almost, it's like, where do you go? So I think that will support staffing efforts within the nursing homes, most definitely.
Great. And Dr. Travers, a question just came in. If I can give you one more, one of our participants appreciates your discussion. She was very pleased to hear that we're trying to get away from this phrase vaccination hesitancy, but she'd like a little more information about strategies to use to increase vaccination rates in the Black community. Can you speak to that at all?
Sure. So first of all, we have to think about information and how information is disseminated. Myself, as an academic, I have privilege, right? I have privilege because of the knowledge that I have, my background, my research. I do research in vaccinations. I am able to tease out this information in real time and be able to say, okay, this is good information and this is bad information. I work in administering vaccinations as well. And I had a patient come in, and some days we give the Johnson & Johnson and other days we give the Pfizer. And I said to the patient, she thought that day was a Johnson & Johnson and that day was actually a Pfizer. So I said, well, why don't you go ahead and just take a seat, go on the side and read up on the Johnson & Johnson and the Pfizer vaccine, because she asked me which one do I think she should get. But I didn't want to impress my opinions onto her. And she told me, well, it's too much information out there. I don't know what to do with it. So recognizing that people don't really know what to do with all of the information out there, and they're looking towards trusted people to actually provide them that information. So what that trusted person looks like can look differently to other people. It could be peers, it could be colleagues, it could be church representatives, for example, community leaders. So that's going to be very much important when thinking about who's giving that information and where that information is coming from. One other aspect when thinking about my own privilege is my Twitter feeds, for example, social media. That's all, pretty reputable information that I'm getting all the time. But when thinking about other people who are not in academic settings, or just thinking about people who are in the community and their social media feeds, if it's feeds full of misinformation, that's the information that's going to really influence what you're thinking and your thoughts about the vaccination. So that's something that we also need to address and really take heart when thinking about how we're approaching these vaccination efforts.
Yes, and on a related note, we have another question asking if there's any good validated model for increasing vaccination take-up among the Latino population. Can anybody speak to that? I can tell you here in Pittsburgh, we've had pretty good luck bringing vaccine to the people. That is, we've partnered with community centers in neighborhoods that are predominantly minority populations, and worked in Casa San Jose, for example, for Latino populations, and in the Operation Better Block and Homewood YMCA to bring vaccine to people. And it's worked out quite well. The uptake has been very well regarded, and we did it in a respectful way. And we had volunteers do this, and it was a way for the health department to get vaccine to communities that they didn't really have the bandwidth to do it themselves, but through a university partnership and a lot of volunteering, we were able to do that. So there are probably some more creative ways to deploy resources in this way. Good questions. Let me go back to one other change. I'd like to get Dr. Douglas involved in this. We've seen approval for vaccination for the pediatric population. What's its likely impact on older adults?
Well, one of the interesting things about children is they don't get as sick. There are not as many deaths. There are not as many intensive care admissions, that sort of thing with children, but they do get infected at a fairly high rate, and they do transmit the virus. So to the extent that, and for many respiratory infections, the big spreaders are the kids. So many homes, for example, if one of these children, 5 to 11 or even the 12 to 18 population gets infected, they can certainly spread it to a mother, a father, a grandmother, a grandfather, anybody else living in the home. And so I'm hopeful that with a sort of rapid uptake of vaccine in this population, that is the 5 to 11 that just got approved, right, that will really cut down on transmission to older people and really help slow down this epidemic.
Great. We had another question. Now, unfortunately, Dr. Travers had to leave, but I think maybe we can raise this with the group, and I'll ask Dr. Harvath to respond. This participant says, trust. Trust is at the heart of everything. Yeah. Having trusted people can demolish fear and stigma and overcome barriers to vaccination. Do you have a perspective here? What can we do to promote trust in this way? Is it a matter of getting leadership from communities or to get more involved? What can we do in this area?
Yes, I appreciate this question. I think in the short run, yes, it's partnerships like you described with community leaders, with church leaders, with groups of people who already have that trust. But for the longer term strategy, what we really need to do is to ensure that our healthcare workforce reflects the diversity of our population. We have to do a better job of recruiting, retaining, graduating more diverse groups of healthcare professionals, and start with pipeline programs so that young people have can see themselves as having a career in healthcare. And I think until such time we can really build a more diverse workforce, we're not going to have the trust that we need in order to address these types of public health issues as they arise in the future.
Great, thank you. We have another question now. It's kind of a broad question, but let me try it out. Are we thinking too narrowly? I'm going to put a few words into this question. Are we thinking too narrowly? We're running to catch up with COVID-19. What do we need to do to be better prepared for the next pandemic? What if we have we learned what we should learn from this experience? And I recognize it's a very dynamic picture, but are we thinking too narrowly, and are we prepared for the next pandemic? Dr. Douglas, I wonder if you can speak to this.
Well, I mean, I think one thing to think about is that I think the network is really a public-private network that develops vaccines actually did a great job here. They came up with a vaccine. So the problem, and now they're coming up with antivirals that look pretty darn good. So and they're all going to help. They're going to help internationally as well as in this country. The problem, therefore, is more in the administration of the vaccine than it is in the development of the vaccine. I mean, I would hope that would pertain in the future as well. You'd have to anticipate that it would. And we have a number of delivery issues have been discussed today, and I think they're all important, and I think people are beginning to work on them, learn a lot. We know a lot more about how to communicate with hesitant populations than we did prior to this epidemic, and right. And I think those are important lessons there, and we can be much better prepared, particularly as it was just mentioned by Dr. Harvath, that if we get a workforce that is diverse and can communicate trust, the kind of trust that helps people believe that what they're saying is really useful for them. I think that's the kind of thing that'll be really important.
Great, thank you. We have another question from a registered nurse in Las Vegas. This is a tough one. It's kind of a hot button issue. I think we read about it all the time. The question is, what is our take on allowing unvaccinated health professionals to use weekly testing in lieu of vaccination at a healthcare facility? This attendee has had some experience in Chinese evangelical communities where there is some reluctance to take vaccine, and even some the religious leadership not coming along with vaccine recommendations. So there is real distrust with CDC, the government, pharmaceuticals, but let's take it one at a time. What is the best strategy right now for healthcare workers? Is it fair? Is it reasonable to insist on vaccination mandates for that population? I know we have a couple of court cases right now in this area, and a great fear of some resignations from healthcare workers in this area. Dr. Harvath, if you're smiling, but I think I'm going to put it on you if you don't mind.
Oh, sure. Well, I'm going to preface my comments by saying that I am not representing either the Gerontological Society of America nor UC Davis Health with these comments. But I believe that as a healthcare professional, there are things that I have to do in order to be fit for duty, if you will. And one of those, I believe, are the vaccines that prevent me from being a vector of spread of disease to vulnerable patients and families. And I want to be respectful that there are different cultural or religious beliefs that may create some hesitancy. And yet, I think that when we're talking about public health and particularly in the context of a global pandemic where millions of people have died and millions more are experiencing long-term chronic debility because of the spread of this, I think there is a responsibility. And as a registered nurse, as a health professional, I think that's part of the public trust, the social contract, if you will, that we have with society, that we will take the measures that are necessary in order to try and protect vulnerable patients from harm. So that's my personal professional view on that. And I recognize that that may not be widely shared within nursing or other health professional circles.
Dr. Douglas, do you have a thought on whether we should require vaccination?
Widely shared with me. I agree with that position. You have a responsibility for your patients to keep them safe and not be at the origin. Particularly, many of these patients are going to be the ones who have the comorbidities that make COVID a more serious disease. So I just think that there's no question that wearing a mask and testing, even if you test twice a week with a PCR, it's just not as good, not anywhere near as good as getting the vaccine.
Right. Thank you. Well, we have a unanimity, I think, in this panel, but this member of the audience is also saying there's so much misinformation out there, and some of our communities get their information largely from these sources. And what will it take to, I guess you might say, give people the science that they are not getting when they get exclusively their information from certain news stations or radio stations or social media. And this is a much larger issue than we can tackle in this session. Okay, well, our time is really just about up. I want to give the audience one more minute to see if there's any other questions people have. I think we've covered so much ground, lots to chew on. I would like to thank everybody for joining us today. You had many good momentum sessions to choose from. We're very pleased you came to ours. I know I've learned something from the questions, and it's really been fun bringing the panel together. I'd like to thank our National Adult Vaccination Program again for sponsoring this momentum session. Thank the GSA staff for arranging this so well, and also the technical support has been excellent. So really has been a pleasure to work with everybody. So thank you all. I think we'll end our session now and enjoy the remainder of the GSA meeting. Thanks again.
Thank you, Stephen. Thank you, Gordon.
Thank you, Steve.